Good morning.
Good morning.
Okay, good morning, Mr. Chairman. Good morning, everybody. Thanks for joining this very interesting session. Well, I would like to share some ideas about my latest treatments with the ABBOTT Supera stent. So I think everybody has a treatment strategy in his head, and for easy, simple lesions, that's quite obvious. Like you see, this patient that I treated before, it was a patient that was treated for CLI, the below the knee, but has also a very limited inflow lesion. We treated with DCB, no doubt about that. Simple lesions, I think we all agree, leave nothing behind. But that same patient, a couple of months later, presented with an ugly lesion at the common femoral. And then, of course, complex lesions, well, the strategy, it's changing. And in our department, almost 10 years ago, we started using Supera on a common basis for the common femoral artery. So then, of course, in our head, strategy has to be discussed. Simple lesions leave nothing behind. Even sometimes in simple lesions, leave the right thing behind. And complex lesions, what is best? Well, and it's not always straightforward, as this patient showed, because she had to come back for persistent ulcerations at the foot. And then so we could check our treatment in the groin. And we were quite astonished because we expected the DCP treatment to be very easy and simple and have good results on 1 year. On the other hand, you see here, the complex lesion treated with the Supera remained very nice and patent, and the DCP remained with problems. So there is questions in a FEMPOP treatment algorithm, and definitely if we go to complex lesions. And that's why we changed a little bit our practice. We changed it in a way that we want to check the vessel first. And how do we check this? Well, we do it with a very gentle, undersized, low inflation balloon. So we know how the calcium, the length of the lesion, the fibrosis, well, how it will react on our vessel check. And then, as we did before, we mostly go for DCB. And of course, we know that the long-term patency in DCB is dependent on the drugs and the type of balloons. But in our daily practice, we have a lot of patients with extensive calcification, long lesions, and then there is a need for a scaffold because there's a mechanical problem. And then we switch from a very gentle approach to a very aggressive approach with oversized ballooning and atherectomy and even shockwave, as was presented before. And then, of course, the big question comes: what is finally defining the long-term patency of a scaffold? Because a lot of scaffolds are on the market, stents are on the market, presenting with good long-term results. How to choose in our daily practice? Because we all know we're confronted with self-expanding stents. Well, we put them in highly calcified vessels which were well prepared, and nevertheless, we've got recoil on the stents. We got parts that are not fully deployed. So there is a scaffold vessel interaction in the very short term, but also on the long term. And this will definitely have an influence on the patency. So what about biomechanics? What about sizing? What about the location of the vessels? Does that influence the final choice in the scaffold? Because when I was in training, and even these days, very few people are looking into these details. And that's why I went a little bit into the literature of engineering, and I got a look on all these tests that are performed on the stents and scaffolds, torsion tests, compression tests, all this. And I'm not going to bother you with a lot of information and technical details, but I just took some examples from that literature. And here you see these pictures, and I think a lot of them speak for themselves. Extension compression tests, well, okay, you can see this is still acceptable, but I was quite astonished. If you look to the images of certain devices when they're on the test bench and you start rotating them and you start creating torsion, which we all know is present in the SFA. If you look, for example, at the lower line, on the right side, you've got the Supera, which is quite capable of coping with these extreme torsions to more than 90 degrees. But some other devices, they just start to infold and create some bad images, as you can see. So with this in mind, almost 10 years ago, we started treating on a common basis very difficult and challenging lesions. This one doesn't look really challenging because it's a very ugly calcified plaque in the right common femoral, not so challenging on itself, but very challenging for the devices, because we all know these cauliflower, bulky, calcified lesions, they exert extreme pressure on the scaffolds if we implant them. So at the beginning, there were definitely question marks there. But nowadays, well, we are definitely reassured. As you can see, the same patient underwent 3 or 4 years later a CT scan for bowel disease, and look at the Supera that is in the common femoral. Very nice sitting there, extremely pushing away that chunk of calcium, nice and round, and even after several years has a very nice patency. So there is definitely interaction between the scaffold and the vessel, and we know these forces. We've got the chronic outward force. Chronic outward force, there's inherent at the stent design itself. But since we scale on a one-on-one with certain devices, we can control chronic outward force. On the other hand, you've got the radial resistive force. The devices need enough strength to keep up with the recoil forces, with the calcium, and definitely when there's local crush, as in these common femorals. So too much chronic outward force is negative, but we need the resistive force. So the biomechanics need to have like a balance between these forces. And that's why it's important, in my opinion, to take a closer look to all the current devices on the market. And if you look then to a Supera stent, well, you see that if you implant it on a one-on-one size in the vessels, whether it's a common femoral or an SFA, the chronic outward force is very low. But on the other hand, the resistive force remains very high because it's inherent in the design of the Supera that is built up with the wires. So if you start treating common femorals, whether it's a focal lesion or a longer lesion, you need that force and also the flexibility. Because definitely when you are treating in the groin, these lesions undergo constantly extreme forces, but also need the flexibility of the hip movements. So you need a modern generation, and you need modern biomechanics. Otherwise, you end up with problems that we can foresee. And that's why we changed our algorithm in treatment of the popliteal artery. At the end of complex lesions, we nowadays always do flex angios. So we take the patient, we bend the knee, and we look how the modern generation devices are behaving in these difficult conditions. And this is an example where we see that you need flexibility in your devices. Otherwise, you create kinking by just moving the knee. So we need low chronic outward force, extreme radial force, but also flexibility and crush resistancy. I will not go over details in the studies, but as you know, a lot of these devices present with very nice results. But I believe if you start treating the common femoral or complex lesions or calcified lesions, it's not only the study results that matter, but also the biomechanics. So I believe it's important to look at these details, especially in our population where we see that most people present with very long lesions. And these patencies, they remain even in very long calcified lesions. But it's not always without a down. Not everything has positive news. Just sometimes a downside. And also with the Supera, there's something that we need to keep in mind. The Supera has extreme radial resistance. That means that you can really pinch on it without compressing, and you can flex it, turn it without being compressed. But this, in the optimal position, that means in the optimal delivery of the device in the vessel. Because if you elongate the device or you compress it too much, you change these forces within the wires in the wall of the stent. And when a Supera is badly deployed, well, this leads to worse results. And this was also proven in the clinical trials, in the Superb trials, where we know that if you elongate the Supera, it's no longer coping with the recoil of the vessel, so the radial resistive force is dramatically dropping. And so we definitely need to pay attention to a very good deployment. But nevertheless, the Supera is capable of coping with extreme calcium, has its inherent flexibility. So it has a very broad range of clinical cases that can be treated with this device. And this was a patient that presented with extreme CLI, but multi-level disease. So he has calcified groins, but also calcified femoral axis and below the knee vessels. So since we started a program of treating the common femoral, we hardly do any endarterectomies anymore, although we're a vascular surgical department. And so this patient presented with multi-level disease, occlusion of the common femoral, occlusion of the popliteal with extensive calcifications, and extreme calcifications of the below the knee. For us, some major remarks: if we cross the common femoral, we want to do it in an intraluminal way. I think that's very important, because if you can treat the calcium and the occlusion from the inside, and you can definitely make room by pushing all the parts to the side, this has a better end result. SFA, well, there's a different story, especially when it's extremely calcified. We go often also for the subintimal plane. So action plan in these patients. Well, first of all, we do the vessel check. Yeah, we do a slow progressive inflation and just see how the calcium is coping. And now and then, in extreme rare cases, we are not able to pushing away the calcium, but in the majority, even with extreme calcified lesions in occlusions, is perfectly possible. And then we evaluate the recoil. And the next step is we go for a very aggressive treatment. Even in a vessel that is only 7 millimeters or 6 or 7 millimeters diameter with extreme calcium, yeah, we go for a vessel prep with an 8 millimeter balloon. We found out in the past, yeah, that it's better to over-dilate the common femoral to create the room to put in the Supera stent and to end up with a very nice expansion, because that's the key element. You need the full expansion of the Supera in order to have this very strong radial forces. In this case, we implanted a 7.5 millimeter. You see that's very big compared to the vessel, but this leads to very good long-term results. Same story in the SFA. For first, the vessel check, very slow, progressive, little bit undersized balloon, 5 millimeter balloon. Sometimes we do a repeated PTA, especially when there's extreme calcium, focal calcium that is sometimes difficult to push away, because we know that if we implant the Supera in a second stage, we need this room to be able to expand the Supera. So we go for a bigger balloon. We oversize the balloon so that we definitely create room to implant a 5.5 millimeter Supera stent. So how do we do this? Well, for us, I work under magnification because I definitely want to see the behavior of the Supera, of the wires of the Supera. So I locate on the bony landmarks together with the roadmap, and then I go for a big magnification, because I want to see how the wires are definitely developing and taking their position. So first of all, definitely we anchor on a distal healthy path. We anchor because from that moment on, when you reach the zones where there's extreme focal calcium, you know that you will have to push very hard on the delivery system to get this Supera fully deployed in these difficult areas. And when you have these areas, it's important to choose the right wire. Take a wire with a high support in the body of the wire. Take a very long and strong sheet that you have a good stable position. And when the Supera starts wiggling, yeah, when it starts moving, when the delivery system is wiggling because you have to push so hard, it's no problem. Yeah, it's no problem at all. We know that the wires in the end will take their position. It's absolutely mandatory that you don't elongate the Supera. So you have to push, and if there's some infolding, you just pull it out again and start moving forward. Finally, you recapture. I always post-dilate, always 100%, to give the wires room to move, and we do the final angio. In this patient, yeah, we've got the extreme calcifications also in the below the knee, as you can see here. So for these typical lesions, I like the latest device, the latest type of wires, which have a very good penetration force, that have a little bended tip, so that you can navigate through the calcium. But nevertheless, this remains very challenging patients. So I've said it before, you need to prep the vessel, you need to make room. So I use oversized balloons, even in a common femoral, where a lot of my colleagues said in the past, my God, an 8mm balloon in a common femoral, how do you do it? Well, just take your time, leave it open, leave it to expansion, and you will see that the Supera nice and slowly deploys in that way. And look for the cell geometry. I think it's important. If you look for the geometry, you know that the placement is right. But in the end, sometimes we end up with these parts that are a little bit stacked or a little bit elongated. Well, we know from colleagues that have images in the past, and also from CT scan, that we see a reorganization. Yeah, we see a reorganization of these wires in the end. But the most important is that you have space to put the Supera in place. And if you take account all these numbers, well, you will see that the clinical results and the patencies on the long term are very successful. So just to conclude very short, we treat common femorals, we treat extreme calcified lesions, but also longer lesions. The longer lesions, well, especially longer lesions, I try to stay intraluminal as long as possible. We used to do a lot with 035 wires, nowadays more and more with the 018 wires, but we definitely use the drilling technique. I always use a torque device, and I spin it very fast, back and forward, without pushing too much. Yeah, so I let the wire find its way downstream. But in these long lesions, yeah, sometimes you encounter really blocks of calcium that are blocking the way. As was in this case. So at a certain point, I was no longer able to advance the wire or the catheter intraluminally. So we had to change the strategy, especially when you see that the wire is buckling up, you know, you're in the subintimal space, but no problem. We moved to a different strategy. We take the wire into a loop. In that case, when I decide to go for a subintimal plane, I often pre-dilate already my access path, so that I have a little bit more room. So I take a smaller balloon just to pre-dilate and then to find the distal path. But you can see the calcium sitting there. Yeah? And although I pre-dilated and I tried to find an access, I couldn't. Yeah, I always ended up at the popliteal in a subintimal plane with a big space between the true lumen and the subintimal path. So different wires, different catheters. I didn't want to go more distal because that's my surgical landing zone, and so I don't want to spoil that one. So what we changed in the latest years is our technique for retrograde approaches. So before, we also went to the very distal end. So the very distal end, so the tibial vessels. Now, what we do now is we change, and we puncture the popliteal artery, but in an antegrade way. In an anterior way. So we take the window between the tibia and the fibula, we change the fluoro, and under roadmap or under just focusing on the calcium that is sitting there, well, we found out that's the easiest way to do retrograde punctures from the moment that let's say the femoral axis is no longer reachable. So in the end, we fully dilated the whole tract. It was extremely calcified, so we needed to implant a scaffold to maintain the patency. So we implanted 2 Supera stents. We post-dilated, and we finally got a very nice result. So that was my opinion about Supera stents. I think we need definitely to take into account the biomechanics of the scaffolds that we implant. And by doing that, I believe a vessel check is important. But then once you decide that you want to implant, I think we need to go very aggressive to create room to put any implant. Thank you very much.
Thank you. Thank you, Dr. Maene. It was very interesting and useful to see how the decisions are taken depending on the behavior of the vessels with the balloon dilatation. Is there a place, in your opinion, for nitinol stents when we have Supera nowadays? What do you think? Do you use them in some situations?
Well,
for SFA, for common femoral popliteal?
Let's say for common femoral and popliteal, my number one is definitely the VMI Supera. But sometimes, in few cases, when they have these extreme calcium that are not coping with the vessel check and even the vessel prep, you see that there is so much recoil, then I am reluctant to put the Supera in. Because if there is a risk, you have to estimate yourself that the Supera will not fully deploy, then I'd rather not put a Supera in place. But on the other hand, when you have lesions that are very nicely prepped, that you have a good understanding when you do your vessel check, yeah, I think you can put the Supera stent from the common femoral down to the distal popliteal with no doubts. Some lesions may be in redo cases. While there you need not only a mechanical scaffold, but also some drugs to overcome restenosis. So there might be a place for drug-eluting devices, yeah, definitely. But if you compare the first primary patencies in the first lesions, in the first treatment stage, I believe the flexibility and the biomechanics of the Supera have a very strong place.
Thank you. Thank you very much.
There is something I would like to say about the Supera. So, in the common femoral region, I am also advising and recommending devices like stents there. But sometimes you have to go also into the profunda. So that's going to be a problem if you have a Supera, because this is an interwoven stent. If you do a popliteal angioplasty and you are not satisfied, and if you have to put a stent there, then Supera is a good choice. And the problem with the Supera is that you have to know how to deal with the stent. I have seen a lot of Superas floating in the SFA, and this is a big problem. You have to exactly know. I think there is a learning curve how to implant the Supera, and this is one of the main difficulties of Supera. And because the stent is an interwoven stent, and you have very, very, very small space between the stent cells. That's the problem if you cross a profunda. If the profunda is vital for the patient, for the distal part of the extremity, then it's very difficult to go to the stent cells and make a balloon and put another stent there, because the stent is very resilient, and as you see, you can't unkick it. And if you do a balloon, the stent cells always recoils. So you can't. It's very difficult to go into this cell and go to the profunda. But if you do it at the popliteal level, then it's okay. But if you have to also deal with the profunda, then it's a bit tricky and difficult with the Supera. That's what I wanted to say about it.